Hi everyone. Sorry for the slightly late start. I'm Ravi Dhanoa, colleague of Dr. Arsenault's for many years, and I'm the medical director of the Muscle MD Clinic, which I opened about 9 years ago or so. We have 4 clinics across the lower mainland of BC and in Victoria, and we have about 10 physicians working across the clinics. So we'll talk a bit more about that later, so we'll just get straight into it to make up on lost time. We have quite a few topics to cover, so we'll sort of focus on just the sort of the overview of what we do at the clinics and a bit more about myofascial pain, which I'll discuss shortly. And I want to leave a bit more time for questions and answers and sort of talk about the practical aspects, because I'm sure lots of detailed medical knowledge is probably not necessary, as opposed to sort of, how this can impact people that suffer with myofascial pain. So in terms of disclosure, I have nothing to disclose. I have no sponsorships elsewhere. I'm solely focused on working at the clinics and nothing more, which is great. Another nice thing is because we're not using lots of pharmaceuticals, I never have drug reps knocking on my door, which makes me extremely happy after many years in clinical practice. So in terms of objectives, let's go back a second. We're going to talk through the definition of trigger points, myofascial pain. We're going to define myofascial pain syndrome, and we'll talk a bit more in detail about trigger point injections and their application. And I think the most important thing for most patients is the last part, which is tips for treatment, as many patients sort of come in not knowing what to expect. Let's move on to the next slide here before everything crashes again. Again, please let me know if I'm going too fast, too slow. I have a tendency to ramble quite a lot, as my patients will already know. So we'll start with the basics. What is a trigger point? Now, this is a term that's thrown around a lot these days, and it's become quite trendy. It's the kale of the medical world, which makes me very happy. But what it boils down to is it's an abnormality in the muscles in our body, usually the skeletal muscle, meaning the stuff we can voluntarily contract, like our biceps or our shoulder muscles, the trapezius, etc. And nowadays, we're able to look at these using ultrasound imaging and various sort of medical testing methods. In essence, it's a contracted band of muscle. Sometimes it's felt as a long strand. If you press hard enough over the muscle that's affected, you'll be able to feel like a long band, almost like a cord or an electrical wire even, or you can feel it in terms of knots. So a lot of people that go for massages or physio will often be told that they're feeling that a lot of knots are palpable. And as time goes on, these knots can multiply, so to speak, and they can get larger in size, the more muscle fibers that are in spasm. And the other point is it's a peripheral nociceptor, meaning it's a pain generator. So somewhere in your body, whether it's your legs or your glutes or your shoulders or your arms, you develop these knots of muscle, these trigger points, and they can send pain signals to the body. This usually happens when you apply direct pressure over the trigger point. And what that can do is it can cause a characteristic referral of pain to different parts of the body. So, for example, I'll refer to the shoulders quite a lot because that's a very common area for a lot of people suffering with myofascial pain. People often will feel when they put pressure on certain parts of the trapezius muscle in their shoulder, they'll feel the pain radiate up the back of the head or around their eyes or to their temple area, which can mimic many of the sort of features of a migraine or tension headache. And similarly, if in the lower back, in the gluteal region, you can often find trigger points in the glutes and apply pressure, and it will send a referring pain down the leg or into the groin. And they often get told they have sciatica or hip issues or bursitis. So it's quite it sounds very simple on the surface, but it's actually quite complicated because myofascial pain, which we'll talk about, that comes from these trigger points can mimic many other conditions. Now, the next part is it's modulated by the autonomic nervous system, which means these trigger points, these knots of muscle, even though they seem relatively benign, can be far, far away from from your brain itself, and they can be in the lower leg, in the calf muscle, or in the forearm. But when they're abnormal and they sort of act up, they can actually send feedback to the nervous system and cause an autonomic nervous response, such as sweating, dizziness, and nausea. So they're not so benign after all. And, we don't really look at a trigger point in isolation as a bit of abnormal muscle. In fact, it's actually part of a larger process of central sensitization, which I'm sure some of you know quite a bit about. And at the bottom part, which is important from our standpoint, is it can result in muscle dysfunction and pain. Dysfunction meaning the muscles simply not operating properly. It can cause restriction in range of motion, so extreme tightness. So if you think of a frozen shoulder, again, a very common diagnosis, a misdiagnosis. Patients not able to lift their arm up fully, and sometimes it's thought by their treating physician that they have an issue in the shoulder joint itself, whereas actually it's coming from the surrounding muscles. So there are many different manifestations of trigger points and different sorts of pain, which we'll touch on as well. Hopefully you guys can see this picture here, and you can see this is an ultrasound image, and you can see the arrows pointing down to sort of white streakiness in the middle of the screen, and that is actually a trigger point. And this has only come about in the last sort of decade or so, whereas before it was based on purely palpation. Now we are able to use imaging to identify particularly tense trigger points. So what you're seeing here in the imaging is just a very densely packed area of muscle fibers. So you take your normal muscles that contract and relax. When a trigger point forms, the muscle just stays contracted, and more surrounding muscle fibers become contracted to create this little angry ball of muscle, which can have an abnormal pH level, so more acidic, abnormal nerve firing as well. So what we found is this little ball of muscle is a little microenvironment within the muscle itself, and it's abnormal compared to the surrounding tissues. So this has sort of helped validate what trigger points are. And as the ultrasound machines get better and better, we're getting better at picking these up, which is fantastic, because with a lot of things in medicine, you sort of describe stuff, we feed it and say that's what it is, but it's hard to often see things without, you know, having a definitive blood test or imaging. So the fact that we're able to see this now is very reassuring for patients as well. It really validates what trigger points are. Again, the definitions are pretty straightforward. Myofascial pain is pain associated with inflammation or irritation of the muscle or of the fascia surrounding the muscle. Now, fascia is the surrounding tissue over a muscle. The best way to describe it is if you look at a chicken breast before you cook it, you peel off a thin, transparent layer of tissue, which you sort of take off. That is what the fascia is, and all our muscles in our body have this. And we used to think fascia was inert and harmless and not important, but in fact, it's a living tissue that interacts and interfaces with the muscles and joints very intimately. And when you have damage to the fascia, it can cause abnormal muscle firing and the development of trigger points. You can also have thickening of the fascia too, which can restrict range of motion, and that can be caused by a number of things, which we'll talk about. So there you go. That's the detail. It's really not super important, but the bottom line here is it's made of collagen fibers, which a lot of cells in our body have collagen in them, a lot of layers of tissue, and it holds everything in place. Without fascia, it would be a blob on the floor, basically. We wouldn't be able to get up or do anything. So fascia has a structural component. It holds us upright. It supports our tissues. Think of tents being supported by tent pegs to sort of stand upright. And that's what it's doing. But it has lots and lots of tiny nerves in it too. And it's those nerves that will cause a lot of the symptoms of myofascial pain. It's not just sharp shooting pain. You can feel burning, pins and needles, and other things that we associate with bigger nerves that we talk about, like sciatica and carpal tunnel. But the fascia is this all-encompassing layer across the whole body. So we have it under our skin as well. And so you can have pain shooting from the top of your head all the way down to your toes. There is no common nerve that does that. It's actually the fascia. And fortunately for us, more and more people are doing studies on this. So I'm just getting some messages from people, and they say they can't see the image here. I apologize again for the technical difficulties we're having. So I'm just going to try and go through manually here. Can someone message me to let me know if they can see the slides? Can they see the ultrasound image right now? Send a quick message if you can see it before I carry on.
We can see the slide.
Which one can you see right now?
It says, what is fascia?
Okay, perfect. Perfect. Okay, good. So I had a few people message saying they can't see anything. All right, so let's move on to the next slide. Can you see that one as well, Rick?
Yep, looks good.
Perfect, excellent. Sorry, I apologize, everyone. For some reason, of all the days to pick, my laptop has decided today's the day it's going to make my life difficult. So I'm working in a high stress environment right now with not much feedback to go on. So please message me if things go sideways, and I'll try and fix it as best as I can. All right, so this takes us to myofascial pain syndrome. Again, a term that's used quite sparingly these days, and a lot of people are being diagnosed with this condition, which has its pros and cons. Oftentimes, specialists such as rheumatologists will examine a patient because there's a concern about lupus or rheumatoid arthritis, and patients present with lots of pain in their muscles. And the specialists say, look, you don't have an autoimmune disease, or the neurologist will say you don't have MS. But nowadays, they are diagnosing patients with myofascial pain syndrome, which is great because it's actually giving a label to something that people have been suffering with for many, many years. And even in my clinical practice a decade ago, the term myofascial pain was poorly understood and not well known by most physicians that are treating all of you guys on a day-to-day basis. The fact that we're able to give this a label and understand this condition a bit better is very, very validating. And it allows us to have a direction to go in terms of treatment approaches. So by definition, myofascial pain syndrome is very vague, but it means it's a chronic pain. So chronic pain is any pain that's lasted more than 3 months. So that covers many, many people. And it's a pain that originates in the muscle and fascia, which often radiates and is associated with particular trigger points. As I mentioned, you may have myofascial pain in the shoulder, where the trapezius muscle contains trigger points that will radiate down the arm or into the neck, etc., etc. Causes often unknown, but they can be related to many different things. The most common ones in non-central sensitization tend to be muscle injuries. So perfect example is you slip on the ice and you fall, and you sort of give yourself a whiplash injury to your neck, and you can develop myofascial pain from that. Car accidents are an extremely common cause of myofascial pain. I can attest to this. I was rear-ended in April of this year in a seemingly sort of minor accident, and as I was hit from behind, I got out of my car and I felt tightness in my neck, my shoulders, my TMJ, and over time it's got a little bit tighter as well. So even trivial injuries can result in the start of myofascial pain. And the other common thing we see is muscle overuse. So I put prolonged postures in brackets, and this tends to be people that work in an office environment. So if you're sitting, staring at a desk like I do, using a computer with poor ergonomics and not standing often or stretching enough, you can develop myofascial pain. And again, it's not on and off. You can have various degrees of myofascial pain. Some people have only mild discomfort when they do a particular activity, whereas on the other extreme, you can have people that have chronic constant tightness, one shoulder's raised higher than the other, your head is slightly turned to one side and it's impossible to turn the other way. These patients will go and see doctors, and doctors will often say, oh, you've got fibrosis. Or the other term I hear very often from allied professionals sometimes is you have scar tissue. There's lots of scar tissue under your skin. It's technically not really a scar. Sometimes it's just tight muscle. And I've seen many patients that have had radiotherapy, for example, for cancer, and they develop this tightness in the neck, and they're often told it's just scar tissue. You're going to have to live with it. There's nothing you can do. But they receive treatment with trigger point injections, etc., and their scar tissue miraculously disappears. Now, of course, that's not the case for everybody, but in a large percentage of patients, that's quite true. Okay, so myofascial pain syndrome, another important point is it's a great mimicker. As I mentioned, patients will develop symptoms such as numbness and tingling in parts of their body, or tingling and pain in their thumb, index finger, and middle finger, and they think it's carpal tunnel syndrome. They'll go and see various specialists, have MRI scans, nerve testing, which I think is extremely important. But then the test will come back negative, and they'll be told you are absolutely fine, you don't have anything, but they still have the symptoms. So it's quite a cheeky condition because it can really throw patients and physicians off and send you down a different diagnostic pathway. But the important part of that is you do not want to miss other serious conditions because there's such an overlap in the symptoms and how they can present. So I think it is very important for a patient's doctor to do their due diligence and do the workup and not just assume that it's probably myofascial pain syndrome. I like to tell patients, like, I think your numbness and tingling is most likely due to myofascial pain. However, given that the other things that it could be are potentially very serious, we must always exclude them first before developing that tunnel vision. So safety comes first. And the other part of it is you can have myofascial pain syndrome and another condition as well. So it does get a bit confusing. So it's all the more important that when you do see a doctor for a particular set of symptoms, it's worth the physician going down the regular pathway of assessment and diagnostic investigations to make sure something else is not missed. Because if you miss myofascial pain syndrome, that's okay. We can treat that down the road. It's not potentially fatal or dangerous. But if you miss other conditions, that can be extremely dangerous. All right. So exactly, I love this slide just because I used to love Futurama. Patients come with stiff neck all the time, and usually it's just a stiff neck. It's usually stress related, but it could be something else. So it's really, really important to sort of pay attention to these things and never assume. And I have seen referrals from physicians, unfortunately, that I've seen a patient with lower back pain that's going down the legs, and they tell me it's myofascial pain. They come in, we assess them, do a neurological examination, and it turns out they have compression of their spinal cord. They have to be sent for urgent surgery. So it does get missed sometimes. So it's important that when you see a doctor, you talk about all your symptoms and not just assume just because you have a label of a condition, whether it's fibromyalgia, myofascial pain syndrome, ME, it's very easy and dangerous to assume that whatever symptoms you're having moving forward are related to that condition. So it's important for patients to advocate for themselves to make sure they get a complete assessment, and because it's much easier to assume it's nothing else. All right, I like this slide because this is a typical day in Vancouver. Causes of acute myofascial pain. These are a little bit extreme apart from the car ones. I've seen stuff like this in Vancouver for sure. But, sports injuries, car accidents, yeah, it's pretty self-explanatory. In the top right, you see a guy slumped over a bench. Often what that refers to is being in a very poor ergonomic position for a long period of time. Again, this is a bit extreme, but I have seen myofascial pain as a result of many of these sorts of injuries. And the amazing driving in Vancouver as well, for those of you that live here. One of my favorite slides that I show in every single show, a presentation, is the evolution of man. As you can see on the left, we started as apes, and on the right, we're turning into apes again. That position on the right is very typical for a doctor in an office that's about 20 square feet on a stool hunched in the corner. What it illustrates is we have changed the way we use our bodies. And as I always tell my physician colleagues, we are not designed to sit at a computer desk or look down at our phone or iPad or whatever and play games or send memes as I do. But we're meant to be using our body, as in the guy in the middle, for hunting, for farming, for heavy lifting. So one of the most common causes is ergonomics. And if I look at our patient populations in our clinics, a large chunk of those patients have very sedentary lifestyles and jobs, meaning they're doctors, lawyers, accountants, people working in customer support where they're sitting at a desk holding a phone awkwardly between their ear and their shoulder. So it's extremely common for people to develop chronic myofascial pain. Usually it starts very slowly and they don't really notice. Sometimes they feel their neck's a bit tight. But as time goes on, things slowly get tighter and tighter and tighter until they get up one day and they find they have a very hard time checking the blind spot when they drive their car. Sometimes you can have an occupation where you are sedentary or doing repetitive motions. If you're working in a production line in a factory, you're dealing with 1,000 items repeatedly throughout the day. That repetitive motion can help you sort of get tighter and tighter muscles. And then you have a very trivial injury like a small trip, and suddenly your neck goes into spasm. And it stays in spasm, and as time goes on, it gets worse and worse. And that's a very common thing we see in our clinics as well. So the impact of myofascial pain, it's huge. They say chronic pain affects 10 to 15% of the world population. I would disagree with that statistic from 2015. I'm pretty sure it's more than that, but that's just anecdotal. It's pain is defined in different ways. Sometimes people define tightness as pain or pain as tightness. Different cultural biases towards what pain is and attitudes or talking about it. So it's a complicated statistic, but even if it was 5% of the world population, that's a lot of people that are suffering. And in the USA, myofascial pain is the leading cause of disability. And again, the severity varies, but it can really debilitate people. I tell my patients that myofascial pain is not life-threatening in most cases, but it is life-changing. And it's really important that we pay attention to this condition because it's very easy. And again, I'm guilty of this. I did family practice for 4 years on Vancouver Island when I first came to Canada. When I see a patient with myofascial pain, my standard response was take some anti-inflammatories, go and see a massage therapist and go and see a physiotherapist without actually knowing what it is and what they're going to do, because that's how we're trained. Myofascial pain, muscular pain, it's a sprain or a strain, go and get some physio and leave it to them to figure it out and stuff. And over the years, physios have got a lot better at managing myofascial pain with IMS and other treatments, but we'll talk about that a bit more. So it's an extremely important condition. It can change people's lives. It can change their relationships. It can change their mood and their attitude towards the healthcare system. And that can limit how much help they can get, which is completely understandable. So lifetime prevalence is 85% of the USA. That means 85% of the population at some point will suffer with myofascial pain. That is huge. Again, the severity varies. A lot of people will have myofascial pain, live with it, continue to work and not be impacted, whereas others will be completely debilitated by it. And usually myofascial pain is seen at the family doctor's office or the physio or the massage therapist's office, and also in the emergency department. And on that note, I did a talk to emergency physicians across Canada a few years ago, and we talked about myofascial pain and trigger point injections. And since that time, we get a lot more referrals from the emergency doctors now. Initially, when they see this condition, they would prescribe anti-inflammatories, painkillers, and benzodiazepines and send patients home with a prescription and tell them to see their family doctor. And then the family doctor would say, go and do some physio. So it's just a complete circle. But nowadays, they're actually doing trigger point injections, diagnosing it properly, and then referring them on to the appropriate place. So there is a cultural shift, and that makes me extremely happy because in the decade or so I've been doing this, that's a huge change and one that's needed. Again, I'm sure many of you have experienced this in chronic pain. Patients are often just dished out tons and tons of prescriptions, whether they're, anti-inflammatories, whether they're benzodiazepines, muscle relaxants, or opioids especially. And to be quite frank with you, those things will not fix myofascial pain. They may mask it, but if you have a chronic underlying myofascial pain syndrome, that's not really curative. However, I'm not against pills. I think there is a role for medication in treating chronic pain and myofascial pain especially, but only in the extremes when you need something for breakthrough pain. If things are extremely bad or you wake up in more spasm than normal, it is reasonable. But what we're trying to avoid is what you see in the picture there, which is just overprescription of medications. Every day there's a new wonder pill that helps, but it comes the list of side effects longer than you can imagine. So there is a room for there's a role for medication, but it's not necessarily the first line treatment we should be thinking about when dealing with chronic muscle tightness. So yes, just going back to my previous point, a lot of people are getting prescribed opioids. Now these are slightly older statistics, but a large percentage are getting opioids, meaning whether that's tramadol, Tramoset, those are opioids, they're cousins of morphine, whether it's Tylenol 3, hydromorphone, anything like that is an opioid medication. And if all you're doing is taking painkillers, you will not move forward in terms of treating the pain or restrictions in range of motion. You are simply masking the pain. And that in itself leads to all the issues we're seeing with the opioid epidemic as well. And it's just a downward spiral. But there is hope, and that's why I'm here. No, it was, as I mentioned before, it was a diagnosis of exclusion, which has its pros and cons, meaning when the specialist has looked at everything else and they can't figure it out, they just told patients, you have myofascial pain, see you later. And the patients will leave the office without a clue as to what to do next. Now, when they see a specialist, they still get told you have myofascial pain, but they can be more precise and say, you have myofascial pain of your shoulder, of this muscle, or of your lower back, or wherever, and I think you should do X, Y, Z. which is, again, a huge paradigm shift and very beneficial for patients. I mentioned ultrasound is good for imaging trigger points in the past, but the next line says no reliable modes, which is still true. You can't see all trigger points in ultrasound imaging. And as you know, with the current constraints in our healthcare systems, it's not very easy to get a scan, and specifically of trigger points, because most ultrasonographers in the community are not used to doing ultrasound scans at that level of muscle. They're used to looking at joints themselves or internal organs. So it is tricky, and there aren't any blood tests, which is obviously quite frustrating for patients. So it is still very much a clinical diagnosis, but the physician must lay hands on you and examine you before they can make that diagnosis. I think it's completely inappropriate to tell a patient they have myofascial pain without being examined. And unfortunately, even still, I see many patients when I first meet them and examine them, and I go, wow, that's the first time someone's examined me. And that's extremely unfortunate, because patients need to be physically assessed. You pick up a lot of information by examining patients hands-on. And the only way to reliably diagnose myofascial pain or trigger points is to feel the trigger points themselves. And oftentimes you can feel them if you know what you're looking for. As I mentioned, the attitudes of doctors and allied professionals has changed. I believe that physiotherapists, kinesiologists, massage therapists are leaps and bounds ahead of medical doctors, who are slowly catching up. But the allied professionals have been fantastic in talking about this diagnosis and recommending treatment and trying their own modalities. So that's fantastic. So we talk about conventional approaches and fancy drugs, so the usual, muscle relaxants, etc., were a sort of regular approach. But nowadays, we're not jumping straight to the extreme drugs or surgical procedures, and considering other approaches like physio with IMS or massage therapy or whatever else you can think of, including trigger point injections. And I do some medical legal work, and I'm looking at ICBC cases and sort of court documents, and the term myofascial pain is used very commonly. And as I mentioned before, this is fantastic news. The more we recognize this, the more it's talked about, the more people take interest, the more research is done. The same happened for long COVID as well. I'm sure Dr. Arsenal will attest to that. During the pandemic, a lot more people, unfortunately, were diagnosed, and it brought attention to central sensitivity disorders. Unfortunately, it takes celebrities to get sick for people to take notice. I think Lady Gaga disclosed that she has fibromyalgia many years ago, and all of a sudden it became trendy for people to talk about it in the news. It's frustrating, but sometimes that's what's needed to sort of bring people's attention to it. Otherwise, they will just simply be ignorant of it. Sorry, going the wrong way. Okay, here we go. So getting into the meat of it. That's a pun, sorry. Symptoms of myofascial pain syndrome, as we talked about, a tender part of the muscle. Sometimes there's sensitivity, so patients will often say, hey, when I simply touch this, or a bit of clothing sort of rubs over this area, it can sort of elicit pain or burning. There are many different reasons that can happen. One of them is myofascial pain. And usually it's the direct pressure applied on the trigger point, which causes that characteristic pattern. If you go on Google, the Google Medical School website, if you look at images, you can look for trigger point referral patterns, and you'll start to see these diagrams with a trigger point marked on the body and then a marked area elsewhere far away where the pain will often be felt. So you can have there are these very classic trigger point diagrams that have been around for a very long time that many different therapists use to figure out where the symptoms are coming from. I sometimes see patients that tell me they have pain in their deltoid region, so their upper arm on the outside, and I'll say, look, let's treat your shoulder higher up in the trapezius near the neck. And they'll say, well, I have no pain there. It's because the trigger point isn't necessarily painful until you press on it, but you feel the pain elsewhere when you use that muscle. So it's a bit cheeky sometimes. It can vary. And oftentimes we ask, what is the character of the pain? How can you describe it? Usually the word tight is brought up, and then all those other words I've written down here: achy, burning, stinging, stabbing, tingling. And in the case of central sensitization, when I ask a patient whether it's achy, burning, stinging, stabbing, the patient will often reply with yes, all of the above. And there are many different reasons for that. One of them is myofascial pain. Sometimes, but not always, patients will have reduced range of motion. So as I mentioned, the frozen shoulder example in the past, when a patient lifts up their arm, they feel pain shooting down their arm and they're not able to lift it too high. And oftentimes they'll go to the doctor, and the doctor will say, oh, I think you have adhesive capsulitis, which is the fancy name for frozen shoulder. and they'll get a steroid injection in their shoulder, which may give them a day or two of relief for a week or two, and then it comes back again. There is such a thing as adhesive capsulitis, but again, that's the first thing we think about. But it could simply be tight muscle around the shoulder, and simply treating the muscles around the shoulder can get rid of that reduced range of motion. And it's quite miraculous. And the other part is a subjective feeling of weakness. And but not always, because sometimes a patient will say, look, my arm feels very weak. But when we actually examine the patient, their strength is perfect. But because of the tightness of the muscle, there's a perception that the muscle's not able to do as much. So as you can see from what I've described so far, it's very confusing. It can manifest in many, many different ways. And this is why doctors can often miss it. So if you have symptoms and you think, hey, could this be myofascial pain? Bring this up with your physician. Say, could this be a trigger point? And then they'll go, aha, I haven't thought about that yet. Or they'll say, what's a trigger point? Which is unfortunately still happening. Now, something more relevant, myofascial pain syndrome versus fibromyalgia. It's very important to know that it's not the same thing. Sometimes it's used interchangeably. You can have myofascial pain syndrome without fibromyalgia, and you can have fibromyalgia without myofascial pain syndrome. But more often than not, you have both of them together when you have fibromyalgia. Myofascial pain syndrome, as you can see on the left, can be caused by acute things, so sort of sudden injuries, car accidents, MBAs, motor vehicle accident, or as I mentioned before, repetitive motions and poor posture. And I mentioned systemic illness there. By that I mean if you have an underlying medical condition such as MS or rheumatoid arthritis or Parkinson's, you can develop trigger points as well. And those are a lot more complicated to treat, and I'll touch on that a bit later. In terms of fibromyalgia, classically in the past, a tender point examination was used where the doctor presses on different parts of the body and the patient goes, ouch, but the pain doesn't necessarily radiate to other parts of the body. So again, gets more confusing. So by the end of this talk, everyone's going to be even more confused, but hopefully I'll be able to answer some questions. Okay, in terms of treatment options, I've talked about the medications. So you've got all the fun stuff, the non-steroidals, meaning stuff like ibuprofen, naproxen, Celebrex, and all those things. And unfortunately, a lot of patients end up on these medications for years, sometimes decades, which can have very detrimental effects on their health. Long-term use of steroids is associated with cardiac issues and renal issues, so kidney failure can happen. I've seen that happen to people close to me, unfortunately, all due to pain. Muscle relaxants, Robaxacet, and the other prescription ones like baclofen and cyclobenzaprine. Again, these might give short-term relief, but they carry their own side effects, such as drowsiness. And the other typical analgesics, meaning painkillers, such as Tylenol and all the sort of heavy-hitting ones like morphine. And again, the benefit is varying, but if you have true myofascial pain syndrome, you're not going to get long-term benefit from these medications. They are simply a band-aid to control the pain in the moment. And as I've mentioned before, be mindful of the side effects of these medications. I've seen patients using ibuprofen for a long time developing stomach ulcers because it causes an increased acidity in the stomach, they develop ulceration, there's a risk of bleeding. So even though the medications are over the counter for a seemingly benign condition, the effects of the medication themselves can be a lot more serious than the actual condition. So moving away from the medications, we're looking at physiotherapy. Physiotherapists have been amazing, and they're getting increasingly amazing at dealing with myofascial pain and also diagnosing it early and letting the family doctor know, hey, I think this patient has myofascial pain or trigger points. What do you think about referring them for trigger point injections? And then patients will come in and say, well, actually, my physio is the one that told me about this place. My family doctor had no idea who you guys were, but now they know. So physios not only diagnose, they can work through exercises and also have other interventions, whether it's ultrasound, shockwave, or IMS, which is intramuscular stimulation. That's dry needling, where they use a very small, thin acupuncture needle and they leave it in, and it's quite painful and it takes quite a while. Massage therapy, again, a fantastic modality. Massage therapists are brilliant at diagnosing this because they will spend 45 minutes to an hour plus examining your body with their hands. And they're very good at identifying particular knots and sort of the trouble issues that they can then pass on to the patient, who can then tell the doctor treating them. So it's been brilliant. So as I mentioned, acupuncture as well. Acupuncture has been around for thousands of years. There's established evidence for acupuncture being amazing. It's not the same as IMS or trigger point injections, but as you'll see, there's a lot of overlap between all these treatment modalities. And these terms are used interchangeably, which leads to confusion, not only for the patients, but also for the doctors treating them as well. Prolotherapy is another type of treatment where we're using a high concentration of dextrose, which is sugar, and targeting ligaments, which can be quite loose in conditions such as EDS, which is a hypermobility, the hypermobility type, where all your collagen has developed abnormally, so things are a bit more stretchy than they should be. Prolotherapy is when needles used and dextrose is injected to cause inflammation and tighten up the tissues. This again, results vary drastically between the people doing it. And finally, we come to trigger point injection therapy. Now, this is a very broad term, and the definition of trigger point injections varies. If you go to a naturopath, they may be injecting vitamin B12. You go to an orthopedic surgeon, they may inject steroids. You go to a pain clinic, they may inject lidocaine. It really does vary. And the problem with that is no two people necessarily are doing it the same way. So you want to be aware of what they're using, because trigger point injections in itself is a very broad term. And that brings us on to trigger point injections. Most of you will recognize this chap here, JFK. He's one of the first known famous patients, even before Lady Gaga, who had trigger point injections. He had them for his lower back pain back in the 1960s. And it was done with local anesthetic by Dr. Travell, who wrote the sort of book on trigger point, the Bible on trigger point injections. He was so impressed with the relief he got for his low back pain that he continued to run for president and made her the first White House staff physician. So this is not a new treatment, and that's what this slide illustrates. This treatment's been around for 60-something years. It's just gaining more popularity now because of the medical system and society's frustration with using lots of heavy-duty painkillers and not getting anywhere very fast. So this is why we have more of a push towards these kinds of procedures. And here's the million or the billion-dollar question now: how does it work? We don't actually know. You guys don't need to read all of this stuff. These are many of the different theories that have been postulated. The one to me that makes most sense, based on what I've seen with patients, is the one highlighted in red. By doing this treatment, we're mechanically releasing the muscle when we inject a bit of anesthetic, and we send a message to the brain. As I mentioned before, it's connected directly in terms of the autonomic nervous system to tell the brain that the muscle should be relaxed and not tight. And that's important for a very big reason, which I'll touch on a bit later. So if you repeatedly treat someone in the same area, the muscle will send a message back to the brain and say, hey, look, I'm meant to be relaxed, not tight. And that's important in terms of rehab. So if we do that a few times, the brain usually learns that this is how it's meant to be. Sometimes it doesn't work when you have an underlying condition or an orthopedic problem or severe arthritis where there's an ongoing physical stimulus that makes the muscle go back into being tight again. It's a chicken egg thing. Is the myofascial pain causing the pain, or is another issue causing the myofascial pain? That's where we sort of come in and try and figure that out. So yeah, lots of different theories. We're not going to go into them, but feel free to look back at this. And it's quite interesting. Everyone has their own idea. All we know is it works in a lot of cases. So indications, meaning what do we use it for? Chronic disease, myofascial pain syndrome, fibromyalgia. And it's important to note here that it's not to treat fibromyalgia. It's to treat the trigger points in fibromyalgia. So it's not a catch-all treatment for these chronic conditions, but for components of these conditions. The same thing applies to autoimmune disease and arthritis, fasciitis, again, all these things that patients are often diagnosed with. You go and see a doctor or physio and they'll say, you have tendonitis of your ankle or whatever else. And then you sort of follow that path and get topical anti-inflammatory gels prescribed, but it's just not getting better. That's because there's usually a muscle somewhere in the proximity that's in spasm and it's pulling on that area and causing irritation to those tendons and bursa. So treating the actual tendon itself may not necessarily fix it. You have to treat the surrounding tissues as well. MS, multiple sclerosis, spinal cord injury, Parkinson's, etc. This is not going to fix these conditions, but it can improve the quality of life of patients that suffer from these conditions by allowing more movement and less pain. And this is where it gets more interesting: scar pain and graft pain. We often see patients that have had massive surgeries, whether it's a breast reduction or breast implants or mastectomies for breast cancer or bowel surgery or even appendectomies, who develop pain in the surrounding area, whether it's over the scar or over a graft from a burn or plastic surgery or somewhere nearby. And this is because the fascia, which we talked about earlier, has been injured. So when you cut through the skin in any kind of surgery or any kind of trauma, not only are you cutting through the skin on the surface, you're cutting through the superficial fascia. And the fascia has lots of nerves in. And as the scar heals, instead of the fascia and skin moving freely, it sticks to one another and it acts as an anchor and a sort of point of biomechanical issue where the body doesn't move and flow as smooth as it's meant to. And then surrounding muscles can get quite irritated. So we actually treat that area directly with trigger point injections for pain elsewhere. And my most favorite pain to treat is mysterious pain, NYD. Patients have this abnormal abdominal pain or head pain. They've seen multiple specialists. They've had lots and lots of tests. They're glowing in the dark from all the radiation they've had. And no one can figure it out. And sometimes it's as simple as a trigger point. But again, as funny as that sounds, it's important to go through all the other investigations. But the other pro of this is you can still treat a patient with trigger point injections who has a weird pain, and they can still go through all the other diagnoses at the same time. It's not going to impact it negatively. So for acute, so we mentioned deceleration injuries, meaning whiplash injuries, fall, waking up with a wry neck. I've had colleagues that have woken up in the morning with a wry neck and they get treated and they're back to work within 20 minutes. Frozen shoulder, headaches. And I mentioned non-dangerous because there are 1,000,001 different causes of headaches. So it's important you go through the appropriate history and diagnosis and investigations with your family doctor or specialist before we say it's likely myofascial. You don't want to miss meningitis or a brain tumor or something else. But common things being common, if the history fits, it's probably myofascial pain. Another common thing we see is low back pain. It's tricky to treat, but extremely common. Whether it's from an injury, whether it's from waking up and sleeping in a funny position, it can start a cascade of events that can go on for many years. And menstrual cramps as well. So we see a lot of patients from the pelvic pain clinics that have endometriosis. Again, commonly seen in myofascial pain syndrome and fibromyalgia. And this can respond very well to treatment as well. We're nearly there, guys. Contraindications, meaning people that should not have it, people that have a bleeding risk, so people that are taking anticoagulant medication for blood clots, such as warfarin. There's an asterisk there because we can treat those patients, but we have to take a more cautious approach with smaller needles and more shallow treatment. Pregnancy, we have no data in the medical world to show whether it's safe or not. So when we don't have data, we don't want to create data by trying to figure that out by treating patients. So as a general precaution, we don't treat you if you're pregnant with lidocaine. We can use dextrose trigger point injections, and that's a discussion for another day, but that's much safer. Local skin infections, if your skin is an open sore in the area, we're not going to put needles in there for many reasons. It can lead to infection because the barrier is gone. It can cause more pain as well. And severe needle phobia, again, another asterisk. We can treat patients with needle phobia, and we often do. We just have a slightly different approach because we find that most patients that have a needle phobia tend to do very well with treatment if it's very slow. And, patients will often say, hey, I'm no longer as afraid of needles anymore because the relationship they have with interventions and injections and needles changes when it's actually giving you relief and not just taking your blood for tests, etc. Side effects, commonly asked questions. The most common side effects are bruising. I often have patients come back and say, I got a lot of bruising from that last treatment. And my response will be, yes, you did. And that's completely okay. Small bruises are very common. When you break the skin, you also go through some of the shallow blood vessels there, which is completely safe. And that can leave a bruise under the skin because the blood doesn't escape out of the skin. It stays under and sort of spreads. So it looks quite scary, but it's not at all. That can be alleviated by applying some direct pressure on the area that's sort of bumpy. Soreness in the area of injection for a few hours to a few days. When you get the right spot, when you hit the muscle that's in spasm, the trigger point will release all the metabolites in there. You feel quite exhausted. It again interfaces with your brain and your autonomic nervous system, and you can feel fatigue for quite a while. In the case of central sensitization, whether it's fibromyalgia or ME, this can be quite extreme if you do too much treatment. So we tend to go extremely slowly with next to no treatment at the beginning and slowly titrate based on patient response. What we find is most patients after a few treatments can actually have a much faster recovery, and they just don't feel a sore afterwards either and can get back to normal life within a few hours. But initially, if you do too much, patients can be exhausted and laying in bed for a week at a time. And again, this is more common for groups that have chronic underlying conditions. So it's a very important point. As I mentioned, the metabolite release can lead to the muscles feeling quite tight and fatigued. Few common descriptions I get from patients are, hey, after you treated me last time, it felt like I was hit by a train, or I went for a massive workout and I feel really tired afterwards. Again, that's due to lactate being released and that overall sort of central fatigue. Less common, but we still see these side effects. Some people do get quite sweaty, some feel nauseated, and some people can feel a bit woozy. So what we tend to do is have patients laying down for about 30 seconds to a minute, and afterwards they're completely fine and they can go about their life. Extremely rare. Important to mention, luckily we haven't seen any of this stuff, but it's always possible. And I think when we talk about any kind of procedure, we should never look at it through rose-tinted glasses and say it's completely fine, because someone out there somewhere is going to suffer a side effect that is extremely rare when more and more people are doing this procedure. As with any other procedure where you're sticking needles in people, whether it's deep or shallow, you can injure underlying tissues, meaning, whether it's the lung and you can puncture a lung, which again, touch wood, hasn't happened, but it's quite possible. Nerves, blood vessels as well. People that are trained to do trigger point injections will stay away from all the common larger nerves and blood vessels, so that shouldn't be an issue. That's always worth mentioning. And a very, very rare thing, which I have not seen yet in 10 years, is skin infection. Usually the skin is sanitized with 70% alcohol plus, or chlorhexidine, or whichever sterile solution. And that's not even necessary in most cases, but it's done. So we generally don't see skin infection. But it's worth being aware of these things. If you were to have treatment, something happens, it becomes quite red, best not to ignore it and just speak to the doctor treating you to figure out what it is. The procedure, we'll sort of skim over this. So when you generally go in, the doctor will, the first time you go in, you'll get examined to look at your range of motion. And that gives us a good baseline for progress. Sometimes when people are having treatment, they are not sure if they're seeing improvement. So if you measure range of motion at the beginning and a few visits in, you can compare and say, well, actually, your shoulder's going a lot higher. Because sometimes the response to treatment is subtle. It's very slow, especially at the beginning. And, if you have central sensitization, we'll go even slower. So you might have 3 or 4 or 5 treatments and you're going to come back and say, look, they didn't do anything. But when we actually start examining your range of motion, which is again a soft marker, you can say, look, your shoulder abduction, lifting your shoulder up towards your head, has doubled. So, and that's validating for patients. Palpating, so feeling the region to identify the knots, which are the trigger points. Again, cleaning the skin and inserting usually a small needle, depending on where it is. Hypodermic, meaning you can under the skin and you can inject through it, and you inject it directly into the trigger point. When you hit the right spot, you usually get a twitch response. So this means you'll feel the muscle burn a little bit or cramp. It lasts a few seconds and then it dissipates. As a doctor treating the patient, we often see and feel the muscle jump, especially in the upper body. And that is good feedback for us that that's where we need to be. And we put a few drops of solution in, and it's usually lidocaine, which is a local anesthetic that we use in the dentist's office. And this is important. You can treat a few different trigger points at each visit, but you don't want to do too many, especially at the beginning, because the more you treat, the more exhausted and sore you'll be afterwards. And at the beginning, you want to introduce the treatment to the patient so they know what to expect, because it is quite scary going into a doctor's office and knowing there are a bunch of needles there on the table and you don't know what's going to happen. And you'll talk to your friends and colleagues and neighbors and they'll say, well, I went to the doctor and he gave me 1,000 injections, etc., etc. to hear all the stories. So it's really important to know, starting slow, doing a few areas, sometimes 1 or 2 little injections. The procedure takes just a few seconds and then that's it. And aftercare, which I'll touch on in a moment as well, includes stretching, gentle cardio, and heat and ice. Now, what can you do to prepare for treatment? If you've never had trigger point injections before, or even if you do have them now, make sure you wear clothing that's easy to remove or move out of the way. I see people come in with shoulder pain that wear turtlenecks and nothing else underneath, which can be awkward sometimes. We do have gowns in our clinics, but it's just easier to wear something. If you're wearing a tank top, have spaghetti straps or elastic at your waist, just like you're going to the gym or the physio and stuff. It makes it easier for you as well. Don't wear light colored clothing because sometimes you get a drop of blood on your clothing and that's more of a pain to deal with. So that's important. Or you can have a friend or family member accompany you to the appointment if you're worried that, especially if you have central sensitization, you can get a bit of fatigue or flare up of pain. You want someone to be there with you or drive you home. That's usually not necessary, but happens in extreme cases. And another very, very important point, please eat your breakfast or drink your tea, coffee, whatever sugary drink before you come in, because if you don't, there's a chance you may faint because your blood sugar is already low, your blood pressure is low. So you want to make sure you've eaten a meal, and that really reduces your chance of feeling dizzy or lightheaded. The next point is you can take pain medication beforehand, whether it's Tylenol or Advil before treatment, about an hour before, to sort of preload with some analgesia so that the treatment is not as uncomfortable. Usually it's not too bad anyway, and most people tolerate it completely fine. Some patients will use topical anesthetic cream that they apply. So they get the cream from the pharmacy, so lidocaine, apply it about 45 minutes before. You can put some saran wrap over it in the area that you're going to have treated. So the skin is quite numb. So when the needle punctures the skin, you don't feel it. You will, however, still feel the twitch response because that's a much more complicated response directly wired to the muscle and the brain. But again, I have 0 patients at the moment that do that because most of the time the treatment is super quick and it's over before you know it and you're not too sore afterwards. And the other important point is to have a light schedule after treatment. We treat a lot of non-central sensitization patients that are athletes, and as soon as they finish the treatment, they run off and go powerlifting or playing tennis, which is great and everything. But if you want to increase your risk of more pain afterwards, do it. But if you want to improve your likelihood of faster recovery and needing less treatment, try and take it easy afterwards. That doesn't mean lay in bed. Whether it means go for a light walk or just stay active around the home, that's completely fine. Aftercare. Touched on this earlier, heat versus cold. Patients often ask, which is better? And the answer is whichever one you like. There is no real sort of gold standard. I see most patients prefer heat because it just relaxes the muscle afterwards. I tend to avoid sending patients to the hot tub straight after because you just puncture the skin. You don't want bugs getting in there and stuff. Stretching is really important. Stretch as much as you can afterwards and throughout the day. And whether you had treatment that day or not, stretching the muscles will help prevent them getting tighter. So pushing yourself to the range of motion that you're comfortable with. So turning your neck, for example, with your shoulders treated, turning your neck to the left and the right and the side, pulling your arm down. The physios have brilliant stretches for this stuff. And do that throughout the day. Avoid heavy lifting. A lot of patients will want to do weight training afterwards or do push-ups and planks, for example, when they have shoulder pain, or squats and deadlifts when they have back pain. My recommendation is avoid all this stuff until you're feeling better. Same goes for repetitive movements or prolonged postures. I mentioned conflicting advice because a lot of the times patients come in, they'll say, my physio told me, or my kinesiologist told me I need to strengthen my core so my lower back pain goes away. So I'm doing deadlifts and lunges and all this stuff. But oftentimes the pain is actually coming from the glute muscle. And when we just treated a muscle that's in spasm, and we're sending the message to the brain that it should be relaxed, by going and exercising with high high repetition or heavy loads, you're going to send that muscle right back into spasm. So what happens is you have this ping pong effect. The patient comes and gets treated and they go, I feel better for a few days, but then it comes back again. And oftentimes it's because there's something the patient's doing after they leave the clinic that's contributing to this. So there is a lot of conflicting sort of advice that patients get, and I feel bad for patients going to see different practitioners because everyone has their own idea, but oftentimes it's strengthen, strengthen, strengthen. Now, I do agree strengthening is important, but once you feel better. A lot of people will have anxiety or depression and they treat it with exercise as a form of medicine. And, that's important. So what I say is if you need to exercise, just go gentle. Go do gentle cardio, whether it's cycling or walking or elliptical. If you're going to do weightlifting, sure, go for it. Really lighten the weight. And when you start lifting, or whether you're doing yoga or whatever, once you start to feel pain with a particular movement or exercise, just back off and do a little bit less so you're not in that sort of pain zone. If you're away from the pain zone, generally that much exercise is okay. The other point is avoid other treatments in the same area. Many patients are seeing multiple practitioners, and on Monday you'll see us, on Tuesday you'll see a physio, on Wednesday you'll see a kinesiologist, on Thursday you'll see an RMT, and everyone has an idea of what to do to make you feel better, and they'll all be at it, whether they're treating with needles or massage or whatever. My advice is do one thing at a time in one area, because sometimes you may suffer side effects and there's a delay between getting IMS or trigger point and then the side effect. And it's really hard to know what's causing what. And also, the trigger points themselves, the muscle needs time to recover. So as much as people are motivated to do everything at the same time, try and schedule it so that you're actually spacing things out and giving it a few days in between treatments to see what's helping and what's not. Otherwise, you're in this constant cycle of treatment and recovery. And also return to activity. So to get back to your usual activities, or whether you're more active and doing more weight training, take your time and slowly increase the intensity. We're nearly there. Okay, so variations in trigger point injection techniques. As I mentioned, it's an umbrella term. Everybody and their dog is now doing trigger point injections, and they're doing it in different ways. I have many different descriptions. Some scare me, some reassure me. Some people are injecting extremely large volumes of local anesthetic, which can have potential risks. Low volume of anesthetic, so a mil or two, is completely safe. It doesn't generally have any side effects. But when you put large volumes in, it can affect the heart as well and your heart rhythm. So it's important to know what's being injected and how much. And funnily enough, most patients I see, about 3 visits in, will say, so what is it that you're injecting? And this is something we've explained at the first visit, but as I'm overwhelming you guys with information, you come in to see the doctor, you're anxious, you're worried, you're suffering in pain already. The doctor just spurts a bunch of information out at you, and then you leave and you have no idea what just happened. Then you feel sore afterwards. So it is disorienting. So it's important to know what it is that's being injected. Feel free to ask whichever doctor you see, whatever questions you have. Again, twitch versus no twitch. Some doctors will inject where it's just tender and inject directly in and put some anesthetic in or steroid. Some doctors will look for the twitch, which is what we often do when the muscle jumps. There are different techniques. Some doctors will put the needle in one place and fan and spread the needle around, which works for some areas, but in other areas you can potentially cause damage. So we tend to do individual insertions, and when we get a twitch, we inject. Cortisone versus no cortisone. Some research has shown that some steroid injections can be marginally beneficial, especially in non-cancer pain, but most of the time you don't need steroid because there are so many side effects that you have to be mindful of. And again, in red is what we mostly do: lidocaine versus saline versus dextrose versus Botox. Botox is more specialized, and that's something I do for chronic muscle spasm, migraines, and TMJ when everything else has failed. And again, as I mentioned, naturopaths use B12 and magnesium and other things. The evidence shows there's no significant difference between all the other additives that are injected. Lidocaine is more than sufficient. Even saline can help, but marginally less so than lidocaine. And patient experiences vary. I've had patients that have paid $500 in the United States for trigger point injections in California just recently for one treatment of their shoulder. And other patients pay a lot less, and some provinces cover it and some don't. It's all over the place. So no two experiences are generally the same. And that brings me on to the next part. There is no gold standard of technique. It's what's practiced in that area, whether it's that province or whether a particular clinic. So you have to do your research. Benefits, we sort of touched on this as well. We hope that it improves pain. You know, in many cases, it doesn't get rid of the pain completely, but it can really reduce the baseline level of pain, which means you can have better function, whether it's more range of motion, or you're able to walk further without pain, or, you know, sleep a little bit easier, and, you know, you can check your blind spot. Those are all victories. So with what we do, we aim for small victories. We're not looking to fix everything. That's not realistic. You know, it's hopefully to just step by step bring you closer to better function. And the other part is it's one part in the toolbox. A lot of patients will rely on trigger point injections to fix everything. That is not the case. It does not. It should be a targeted approach for the most common areas, because you cannot inject someone from head to toe. And you should not, although people do sometimes. Considerations, as I mentioned, not curative, but it's an adjunct, meaning you can use it in conjunction with other treatments. And one of the main priorities is to reduce the medication usage, whether it's opioids or other things that cause side effects. On the whole, side effects from trigger point injections are usually short-lived, and they're nowhere near as severe as the common side effects from medications. Progress can be slow. Please be patient. And it's especially slow when you have fibromyalgia or ME or long COVID, because we tend to go slower. Because if you do too much, you will have a flare. So you need to go extremely slowly, to the point that it's frustrating sometimes. And you go, you didn't do much today. And then you'll say, But hey, you can do a little bit more. It's okay. And then next time you'll come back and say, that was a bit too much. So it's better to go nice and slow and ease into it because it's a long-term investment in your health. The aim is, again, not to completely fix stuff, although that does happen, but it's to improve your function. And I think it's important, whichever practitioner you see for any sort of intervention when you suffer with chronic pain, is you've got to be careful when someone promises you they're going to fix all your problems. That's usually a cue to run in the opposite direction. If someone can say to you, hey, look, I think this will hopefully improve your quality of life and function, that fills me with reassurance. But if someone comes out there and says, look, this is easy, I can cure fibromyalgia with, and I've heard this from doctors, unfortunately, they'll say, I can cure fibromyalgia with a few injections. That's a bit of a red flag. And the other part is the reliance on trigger point injections. We do have some patients that feel they need the whole body treated. It's not practical. You're doing a lot of injections. You have to use a lot more anesthetic to treat the whole body, which I mentioned is not safe. And it becomes a sort of psychological dependence. The objective is, in some cases, we can resolve the pain, you move along. But when you have chronic underlying conditions, it's to manage the pain. So the aim is to sort of do a few treatments initially, try and bring that baseline level of pain down, improve function, and then have a maintenance schedule, which is, hey, we've done 5-10 treatments, you're looking much better than you were, you have flare-ups, so you just come and see us once a month or so, once every 6 weeks, once every 3 weeks, or if you have a pain flare. And in our clinics, we don't discharge patients that have chronic pain. We'll stay with them and work with them as long as needed, with the objective of minimizing the number of visits they need, so they can not be overburdened by all the interventions they have to go through. And again, with every procedure, risks versus benefits have to be considered. If it gets to a point where a patient is having extremely marginal benefit, it's not worth going through that. Getting up in the morning, having enough energy in your energy envelope to get out and see a doctor, get treated, and then recover for a day of relief isn't necessarily helpful. At that point, you need to look at other options as well. These are recent studies in the last few years. These will be in the video you can look at later if you're interested. The important part of these studies are, there are many contradictory findings. Some say this is the best thing ever. Some say it's not as good as other treatments. The problem is the demographic, the patients, and then the complexity of the pain we're dealing with is very hard to standardize. Therefore, the studies are not going to be very helpful in many cases. We do need more studies, but we are getting more and more larger studies, which is fantastic because everybody's taking interest now, which is something that has been my goal in my career. As I mentioned, the more people that study this, the more robust the evidence will be. All right, sorry I rambled. We're still on time-ish. At this point, I believe I'm taking questions, Rick. Is that right?
Yes, it is.
Perfect. I'm just going to go through. I have 88 questions here, so I'm just going to go through a few here, starting at the top. Most of these are to do with my technical ineptness. Let's see. There's a patient that's mentioned they've had 2 treatments and both times they've been extremely lightheaded, almost falling over for about an hour post-injection. And this patient has POTS, which is postural orthostatic tachycardia syndrome. And then it calms down after about an hour. And they had very little pain and headaches in the first week after the treatment. So the patient's asking, should there be more sessions? I bring this question up because so many patients with central sensitization have POTS. And again, that cautious approach is needed. So if a patient does feel quite lightheaded and dizzy afterwards, which can happen with POTS, the approach would generally be to do next to nothing. So 1 to 2 treatments, make sure you're very hydrated beforehand, you've eaten, and go very, very, very slowly. And when you see a doctor, mention the POTS and mention that you'd rather go very, very slowly, because sometimes doctors get excited and they want to fix everything in one go. But I would definitely persevere with this sort of approach. It just needs to be slower. I've had patients that have to lie down for half an hour in extreme cases afterwards because they're so exhausted with the treatment. But after a few treatments, they walk in, they get treated, they walk out, and they can function normally. So it really does depend on the person. But in situations where you do feel quite dizzy and lightheaded because of the POTS and the autonomic activation, you just need to back off. And it's really frustrating getting out of bed and traveling for an hour and then finding parking for 2 hours to get one or two injections, but it's literally the beginning of something bigger. So, every step is a step forward in the right direction. So, and as time goes on, and I've seen this over many, many, many years, it gets easier and the POTS will start to settle down in terms of tolerance. And I've not had a patient with POTS that cannot tolerate this treatment after a number of treatments. All right, let's have a look. How is trigger point injection treatment different from perineural injection? Which one is less invasive or more appropriate for allodynia patients? So allodynia is when you have increased and abnormal sensitivity to pain. Perineural injections are the injection of dextrose just under the skin. Now, this gets very complicated. It's a good question because we actually do dextrose injections and lidocaine. The lidocaine injections tend to target the muscles, so we're getting in for the twitch response. The dextrose injections can as well, but usually we use them over the trigger point and to treat the fascia, and it works in ways we don't even understand yet. Sometimes it's to sort of release the fascia, sometimes to take the pressure off the nerves or off the trigger point. To answer your question, if you have allodynia, the best approach is to use the most gentle approach because any more than that will cause a pain flare. Dextrose is generally the best approach for patients that are extremely sensitive, especially they're sensitive to gentle pressure or touch or even the wind blowing over their skin. People that have had post-herpetic neuralgia or other nerve-related issues do very well with dextrose. And what happens is you can actually get desensitized with the dextrose, and then you can do more invasive treatments if needed. All right, let's see what else we have here. Do you use ultrasound to guide every trigger point injection now? The answer is no, we don't need to. We do need to use ultrasound in areas where there's a risk of damaging underlying structures. Most of the muscles are very superficial, especially in the shoulders and the glutes, etc. And there are safe zones where we can confidently and safely inject without any risk to the patient. And those will be done using palpation techniques. There are other areas, however, where we should definitely use ultrasound, especially around the piriformis muscle because the sciatic nerve runs underneath there in the bottom area. And if you overshoot or miss, you're going to hit the nerve. It's not necessarily dangerous, but it's extremely painful. It's not practical to use ultrasound for every single area. The main purpose of ultrasound is safety, as opposed to trying to identify the trigger point because you can't always see them, or in most cases. So, ultrasound definitely has a role. And when we're getting into sort of tiger territory, maybe around the neck, sometimes in certain areas, or in nerve blocks and other procedures, we'll tend to use ultrasound then. But if you have good training, you've done a lot of anatomy training and the cadaver labs and stuff, there's no need to use it. All right. Can trigger point injections treat tears of the rotator cuff, calcific tendinosis, and bursitis? I touched on this earlier. It's a very good question, actually, because a lot of times we see patients with rotator cuff tears that can initiate sort of a cascade of pain for many years. This is not going to fix the tear of the rotator cuff. But the interesting thing is, the tear of the rotator cuff may be completely painless, but you have pain in your shoulder because the surrounding muscles are in spasm. So whenever you have a significant injury where you've torn a muscle or one of the rotator cuff muscles, the surrounding muscles have probably received quite a bit of trauma as well, and they will go into spasm, like the whiplash type injury. And therefore, treating those muscles can actually help the pain and function, but it is not going to repair those things. And the other thing I like to mention to patients is that they'll come in with a diagnosis of calcific tendinosis, and they've had an X-ray and an ultrasound, and some calcium deposit in their shoulder, and the doctor will say, "You have calcific tendinosis. You need a steroid injection." The tendon. If you take 10 people off the street that have no pain and scan them, 7 of them will probably have calcium deposits from previous inflammation and trauma, but they have no pain, which points to other causes of the pain, and that's where the muscles come in. Someone said trigger point injections hurt and can cause flares. What can I do as to have a positive result? That's a very good question, and we talked about that a bit as well. They are uncomfortable, unfortunately. I had trigger point injections 3 days ago, and I hate them. So it's ironic. I'm the one that dishes them out, but I've also received treatment. The best thing to do, again, is to slow down. There's a few things you can do during the treatment. You can do slow breathing, so 5 seconds in, 5 seconds out. And on the out breath, the doctor can do a few injections, maybe 1 or 2 at a time, then take a few seconds to recompose, and then slowly improve. That's the best way to go. And just do less. I know, unfortunately, we live in a society where we need quick results, and a lot of patients want to get better yesterday. So we end up with patients saying, "I need to get better, like nothing's happening, do more." And then the doctor will try and do more, but it'll be too much. So to really slow things down, and this is something I've learned from experience myself, because I too am guilty of doing too much at once in the past. So now, as I'm older and wiser, I'm doing a lot less. Okay, just going through a few more here. Right. It's mostly questions, points about my slideshow not working properly. All right. How can I avoid bruising after trigger point injections? And can I get a prescription from a regular doctor if I need one? I'm not sure about the last part. Avoiding bruising is difficult because usually the bruises that you get are from very small veins that are superficial. They're just under the skin. What you can do to avoid bruises getting bigger is if you notice you're getting a bruise, what usually happens is you get a bit of a bump under the skin. Apply direct pressure with your finger. The doctor usually does it, but just apply pressure, whether it's over your shoulder or your leg, if you see a bump coming up. If you push down hard and hold it for 30 seconds or so, it will stop the bruise from spreading. And then usually the bruise will heal within a week or two itself. People try applying arnica and stuff, and they've said that it helps. From my experience, I've seen patients that have been applying arnica and other things. It doesn't really get rid of the bruise. What you must understand is a bruise in itself is not doing anything harmful. It gets resorbed by the body over time itself. It changes colors and it goes away. The bruise is not significant for how much treatment you had or how aggressive the treatment was. A simple vein under the skin can puncture and cause a bruise. As simple as that. And again, it's nothing of concern. All right. Let's see what else is going on here. Yes, TMJ dysfunction in tight, it says masseurs, I think it means masseters. So TMJ, again, a common feature of central sensitization. Can that be treated? It is my favorite thing to treat. It's, again, I want to warn everybody out. This is my public service announcement. Be careful where you go and how much you pay for treatment of your TMJ. A lot of oral specialists, or dentists and stuff, will put you through the ringer and charge you thousands of dollars. I'm sure people can attest to that in this chat for trying to fix your TMJ, whether it's oral appliances or procedures or Invisalign or braces. A lot of the times it's coming from tight masseter muscles, not always. And yes, trigger point injections using a combination of dextrose, lidocaine, and unfortunately usually Botox into the masseter muscle, which are the big muscles that protrude on the sides of your face when you clench your teeth. Treating that area with Botox is the most amazing thing in the world, and it gives long-term benefit. Unfortunately, Botox is not covered in PC, but the costs aren't extremely high compared to going to a dentist, but it's worth considering. And it's a huge quality of life improvement because people that have TMJ dysfunction can get wear and tear of their temporomandibular joint just in front of your ear, pain, grinding, and also damage to their teeth. And that gets very, very expensive. So yes, absolutely, TMJ dysfunction is very, very amenable to treatment. Let's have a look. Thoughts on how well patients do with trigger point injections if they have hypermobile connective tissue. Do these patients need ongoing treatment because they so often injure muscles? That's a very good question. We see a lot of people, again, it cohabits with fibromyalgia and ME. EDS is more often than not seen in central sensitization patients than not. And yes, it can respond. It's a very difficult condition, whether it's just hypermobility or Ehlers-Danlos syndrome. You have to be very specific in what you're treating. You can use trigger point injections to treat the actual muscle knots, but there's a misconception that if you treat muscle spasm, that the muscles are going to become really floppy. That's not true. They just go back to normal. However, in patients that have hypermobility, your muscles are working extra hard to hold your joints in place. So sometimes you need a little bit of muscle tightness to stop you dislocating or subluxing, which is a partial dislocation. This happens commonly, especially in the TMJ and the shoulders and the hip as well. For people with hypermobility, they respond well to prolotherapy, which is, as I mentioned, you can use high concentration dextrose to tighten up the ligaments so the joint becomes more tight because the muscles are trying to do the work of the ligaments in that situation. And someone said, can myofascial pain present as numbness and tingling? Absolutely, yes. It's important to remember to make sure everything else has been excluded, especially MS, which a number of patients with fibromyalgia, for example, have been sort of assessed for, and they've been told there is no MS. The next thing they think about is central sensitization. And yes, the fascial injury itself can present as tingling, sometimes even numbness. And we see a lot of patients that have had electrodiagnostic studies, so the nerve conduction studies, and they've been told all the nerves are completely fine. Or I had a patient today actually in clinic who, had a scan of their neck and there's a disc out at one level in the back in the neck, but they have numbness and tingling in their arm, but it doesn't fit the expected distribution of that nerve. So when you see a doctor and you say, "Look, my whole hand is tingling," or "My whole arm is tingling," the doctor can say, "That's not possible because that would be all the nerves in your neck." Sometimes it's myofascial pain. So once other things have been ruled out, it's worth thinking about this as a cause. All right, let's have a look. Would a TENS machine help with this pain? So TENS is transcutaneous electronic nerve stimulation. It does help sometimes. You can buy the Dr. Ho machines and stuff. They're a little bit, for some people, there's benefit, as with every kind of intervention out there. But on the whole, even the physiotherapy grade TENS machines, patients tell me don't really give much relief, apart from the in the moment, because they're stimulating the nerves, but the muscles are not able to relax and reset. So generally, from my experience, and again, I've never used the TENS machine. I speak to patients every day that have. They tend to say it doesn't really give you long-term benefit. Here's an interesting question: can a childhood injury continue to cause pain in that spot at adulthood and form a trigger point that would temporarily be deactivated by massage, only to come back when not resorting to these therapies? That is a very good question, and the answer is yes. That brings me to another point. Sometimes patients will have an injury in their childhood, say they affects the left lower back, and they'll have that pain for years, and suddenly the pain will disappear when they have another injury, which affects another part of their body. And then what happens is you treat them for the pain they came in with, which is on the other part of the body. Once that pain resolves, their old pain from childhood comes back. And the analogy I use to patients is our body doesn't forget, and we develop all these trigger points all over the body, and each of them is screaming at the brain saying, ouch, ouch, ouch. However, some have a louder volume than others. When we treat patients with trigger point injections or whatever else, we're actually turning down the volume, sometimes temporarily, sometimes long term. And once that volume is turned down, you begin to notice all the other screams of pain coming from the different muscles. So pain will often shift, and that's usually a marker of response. So patients will come in. I had a patient today that said, my lower back pain is much better, but now I have pain in my mid back, which I didn't have before. And it's something we didn't even touch. So it's extremely common for things to linger from childhood, and then they sort of get masked in the sea of other things that are coming up. Someone said, can the effects become permanent? I'm not sure if that refers to the therapies or the pain. In some cases, the trigger points can be permanent. Sometimes they respond to Botox when nothing else works, but they tend to come back because there's usually an underlying process or signal that's being sent to the muscles to tighten up, whether that's central sensitization or MS or rheumatoid arthritis. So what we're doing in that situation is we're managing the symptoms and not resolving them completely, which compared to taking pills is sometimes not a bad thing. Can an MRI show trigger points? No, usually not. MRIs are brilliant for looking at the nerves traveling through different areas. Tight muscles can compress nerves and cause neuropractic injuries and other things that sort of mimic nerve injuries, but it's actually just the muscle. But trigger points themselves are harder to image, and to be honest with you, most radiologists will not even look for trigger points unless there's a very big knot and a lot of spasm, in which case they'll just see a tightening of the overall muscle. All right. Probably have time for one or two more questions. How is infrared stroke laser therapy for myofascial pain syndrome? And if you have fear of needles, what can we do? Laser therapy, I have a few colleagues that have done it over the years. Some patients have reported that cold laser therapy is helpful. Most of the time, it's sort of a short-lived benefit. And again, I'm not saying trigger point injections are going to fix everything, but a lot of these treatments will have temporary benefits. So, if you go for a massage, you might get a day of relief and it tightens up again. I myself don't have a lot of experience myself with laser therapy. A few of my colleagues that have done it say it can be very beneficial as an adjunct to trigger point injections. And there are a few doctors out there in the lower mainland of BC that will do trigger point injections and laser therapy. My take on this and many other therapies is go ahead as long as it's not harming you and your wallet. You can try different things because the medical system fails us many times, but do things that you've done your due diligence with and are not likely to cause you harm. Because if conventional approaches have not worked, you're not just going to sit there and wait. You need to look at other options as well. And if you have a fear of needles, what can we do? Usually, if you have a history of anxiety as well, taking an Ativan if you have one beforehand, before you come in, having someone come in with you is very helpful. Let the doctor know straight away. And the other trick that we use is not to show you the needle. Sometimes doctors hold up a big needle and they scare patients. And even though the needle's not for treating, it's for taking the liquid out of their vial, it can really scare patients. Another thing you can do is sort of lay down in case you're worried about fainting and just doing very little treatment, again with the controlled breathing, and that's worked really, really well. Someone said, I've heard you can't receive trigger point injection therapy if you have atrial fibrillation, which is a heart arrhythmia. Is it just if the injections have lidocaine, or is it regardless of what the needle contains? That's not true. You can have trigger point injections with most conditions. In atrial fibrillation, sometimes patients are on warfarin, and if a doctor doesn't feel confident in treating patients on blood thinners, that's a consideration. Lidocaine is used in such small doses in most cases that it does not have any impact on atrial fibrillation. We've had many patients over the last decade that have AF, atrial fibrillation, that have had no issue. And I'll do one more question. Let's have a look. How do you treat internal scar tissue adhesions that are causing pain and swelling internally, post-surgery or colonoscopy? Unfortunately, we can't really do internal trigger point injections. It's just not safe, for one, because you need to do it, with imaging or in a surgical setting. The scar tissue is interesting, as I mentioned earlier. Scar tissue is a broadly used term. Adhesions in the pelvis, for example, can't always be treated, even apart from through the conventional laparoscopic approaches. You can't really reach those, and you shouldn't be messing around with needles trying to get to those bits because that's going to cause problems. Post-surgery, treating the surgical scars themselves can be fantastic, either with lidocaine or dextrose to pull the fascia off the skin and releasing that fascia. That can be an amazing tool that we use every single day. There are some doctors that can do Botox injections in the bladder, for example, and that's done with cystoscopy. So that's nothing we do in conventional practice. I think that's our time, Rick.
That's it. Thank you so much for a great presentation. And
no worries.
we'll see everybody soon. Take care.
Cheers. Bye-bye, everyone.